My name is Danielle Daniels. So I am a pediatric infectious disease attending at Golisano Children's Hospital in Syracuse, part of SUNY Upstate.
And I'm Greg Connors. I'm a pediatric emergency physician and chair of pediatrics at Upstate and also executive director of Upstate Golisano Children's Hospital.
Danny and Greg, thanks for joining us today. Your article in Pediatric Emergency Care, Recognition, Diagnosis, and Management of Measles in the Emergency Department. One of the first lines in your abstract, in the year 2000, measles was declared eliminated in the United States. So maybe a frustrating question, but why is this review needed right now?
Well, a lot of things have changed since 2000. There's more measles circulating nationally and around the world than ever before. Plus, with the rise of vaccine hesitancy, we've just seen a reduction in the number of children, especially in the United States, who are vaccinated against measles, which is, of course, is the best way to prevent measles.
Yeah. I'll say when we first sat down a couple of years ago and talked about doing this review, I think we understood at that point the importance because cases were already on the rise, and then really over the past 2 years, we're seeing that it's just continued to worsen. So I think last year in the U.S. we saw that there were over 2,000 cases of measles, and in the first 2 months of this year, we've seen already half of that in the United States. So we're really about to lose our elimination status, probably when they meet next month to discuss that. And I think that's following what's happening globally. Globally, over the past 6 months, we've seen several countries lose their elimination status. So that includes Canada to the north. Many European countries like the UK and Spain have lost their elimination status recently. And so measles anywhere is a threat everywhere, and that's what we're seeing.
A lot of practicing ED physicians may not have ever seen a true measles case. Myself, I don't think I've seen one, but certainly we get alerts in terms of the outbreaks and where I am, the Philadelphia community. What's the biggest knowledge gap you think clinicians have today about measles?
Josh, I'm going to start with that by taking a bit of a distraction and a side turn. As you may know, I was a resident with your dad at Children's National Medical Center. In fact, we were fellows together too, but he was my senior resident and a very valued chief resident as well. We had a residency director who was named Dr. Arnold Einhorn, who was getting toward the end of his career at that time. He was very influential on your dad and on me. And one thing that he taught me and taught us about measles was the following: kids with measles look measly. And by that, he meant that they have ill appearance. When you see a child with measles-like morbilliform rash, but they're running around the room and happy, that's not the kind of kid you think about with measles. So that's probably the biggest knowledge gap that clinicians have these days, that it's more than the rash and other things, but the general appearance of the child is very important too.
Yeah, and I'll add to that. In medical school, we are taught the classic prodromal 3 C's, so cough, coryza, conjunctivitis. I think that illness script doesn't always perfectly align with the patient we're seeing in front of us. So, a patient may present to your emergency room and they may not have all of those classic, 3 C's. And while usually at least one of those is present in this prodromal state, the CDC definition of fever, rash, and one of the 3 is only sensitive. It has a sensitivity of 75 to 95%. So there are going to be patients who present and may not fit that exact definition. Modified measles presentations, they can occur, in patients who have some degree of underlying immunity. So whether that's one vaccine or no vaccines, and then think about very young infants who have the maternal transfer of antibodies that are still circulating. And so they may present less typical than what we have been taught in our medical school textbooks.
And Danny, going on that, you could probably ask a CHOP intern who spent the last month in the pediatric emergency room, what percentage of your kids have fever, rash, and one of those 3 C's? So if we're speaking to our junior learners who, going back to Greg's point, maybe they're still trying to figure out, who are those ill-appearing kids? What are some of the pearls? How can we teach them? Yes, you're going to see a lot of kids with fever, rash, and viral-like symptoms. how are they going to then take that next step to say, I need to be concerned about measles? Is it the vaccination status? Is it the age?
Well, I think we both want to answer this question, so I'll jump in first. Probably more than anything else, in fact, certainly more than anything else, vaccination status. But I was going to throw in one other little pearl, which is Koplik spots. We have to get in the habit of when measles is on the differential, but maybe there isn't the rash just yet. Thinking to look for Koplik spots, which are little whitish, bluish, tiny little spots that appear inside the cheeks at about the level of the first and second molar with a red kind of collar around them, often in clusters. And those appear when the children are sick, well before they have a rash. If you see them, that's measles. And I've heard of dentists who picked up on measles and that sort of thing ahead of time. It's not something that we're always in the habit of searching for.
And then I'll talk a little bit more, there's the physical exam findings that we talked about, but I think the history is a huge part of that too. And so we need to get back into the habit of asking or looking for vaccination status for these children. And then, knowing our local epidemiology and travel history. So especially right now where we're having outbreaks all over the country, becoming familiar with what's happening in our own community. And if you look at, the patients who are involved in these measles outbreaks, the majority of them, 93% are unvaccinated children and adults. And so really that is a key question you're going to want to ask when a patient comes in and they have all of these non-specific symptoms that may be, adenovirus, but it also could be measles.
I think stressing the importance of a head-to-toe physical exam. How often in these young children we don't look in their mouths. They say, oh, it's not going to be strep throat, so why do I need to look in their mouth? They have clearly a virus. Are there other ways that measles can present atypically? Greg, you mentioned sort of early on seeing those Koplik spots. Are there other sort of atypical presentations we should be aware of?
Yeah, so I'll say that I mentioned this a little bit more, but this modified measles syndrome is sort of, patients who may not have varying degrees of underlying immunity. And so for them, they may present with, in a child who has some sort of immunity, they may present with lower fevers, than the typical, 104, 105 than we hear about. The rash might be modified as well. And so it may not be the exact, head to toe rash that we're typically, told to look for in these patients. And so understanding their vaccination status, their immune status, and sort of looking at the patient in front of you, those are both important there.
The patient comes in. I think a lot of hospitals have, especially in areas where there are outbreaks, have implemented triage nursing questions to pick these kids up early. A kid screens positive for a potential measles case. What's the first couple things that need to happen in terms of isolation precautions, where this patient should be seen in the ED? What are those first few steps that the ED should do?
Well, that's exactly right to talk about isolation precautions. These kids need contact and respiratory isolation. So thinking about the ED setting, the very first thing to do would be put a mask on the child and then escort them to a room where they're by themselves, ideally a room with the special ventilation that goes with respiratory isolation. But whether that's available or not, maybe your ED will have 0 or 1 such room, so it might already be occupied. But that's important too. And then I think it's easy to forget when you're going in and out of the room how important it is to do general isolation precautions, but also use the N95 and other measures to really respect the respiratory isolation that's required.
Yeah, and I think we have to remember just how contagious this virus is. So, I think back in the COVID days, we talked about the R naught a lot. So how many individuals can a single infected individual spread this to? And for measles, that can be up to 18. And we know that this virus sticks around for 2 hours after a patient has been in the waiting room. So I think making sure that we isolate as promptly as we can when they first arrive.
And it's probably a given, but it's really important to know if the staff taking care of the patient are protected themselves against measles with antibodies. Occasionally, there are staff who are not, and it's important to make sure those staff don't come in contact with the patients.
So we'll follow this potential measles patient through the ED. They are picked up in triage, roomed appropriately, isolation precautions are implemented. The clinician sees them, takes their history, does their physical exam, and says, "Yes, I'm concerned for measles." What diagnostic testing should be done at that point?
Yeah, and I'll mention when they first come in as well. That's when right away getting your infection prevention team and alerting the health department. Those are two things that should be, part of that initial process as well. And then the health department, your local health department is going to help with some of this testing. But really you wanting to send off a PCR test, and you're going to want to send serology as well. And so for a PCR test, the highest sensitivity is going to be, either a nasopharyngeal or a throat oropharyngeal. So you can send one of those. And then the more PCR tests that you send, from different areas, the higher the diagnostic yield. So you can also try to send a urine if that's available as well. Sometimes it's practically a little bit harder to get that. So that's going to have the highest sensitivity in those first 3 days of the infection. Whereas the serology, the IgM, that might come after the rash, develop a little bit later into the course. And so you may not get that positive result if you're testing really early in the course. And, as opposed to the PCR, if the patient's coming later with some of the complications, maybe the PCR won't be positive, but the serology will be positive at that point, the IgM. And then you're also sending an IgG. That's not to help diagnose this acute infection, but it is going to help you know what their immune status is in the long run.
We also recommend setting a general respiratory panel, viral respiratory panel as well. There may be comorbidities, or it may turn out that you find what's really giving the child the illness and it's not measles at all.
And no utility for viral culture.
Right.
Good to know. Is there any indication for other blood work to be sent for a patient? Does it matter on their appearance? Does that help the sort of management of measles?
I can't think of a way that specifically helps, unless the general situation, calls for it. I will recommend, though, that the number one complication, we'll probably get to this, but I'll bring it up now, that we see, among the top two are pneumonia. And so a chest x-ray may be indicated. And then, as you mentioned, a good physical exam. And it may turn up otitis media, another common complication of measles. That's potentially bacterial.
We know that there's no antiviral therapy for measles. So what does good ER management look like for a measles patient?
Well, like anybody in the ED, I'm going to say we start with the ABCs, and they're of course important. I mentioned pneumonia as a common complication. Also, also dehydration is an important complication that we see as well. And the whole time, of course, we're thinking about disposition. Does this child need to be admitted or not? It's sort of a first knee-jerk reaction to think, oh, a child may have measles, we probably need to admit. But in fact, it's just a few percent of children with measles who actually need to be admitted. And as we get more familiar with it, we need to go through that decision-making process too. And again, the usual criteria for admission, can't drink, having breathing problems, that kind of thing, are apply to measles as well. It's best to keep a child who doesn't need to be admitted, who has measles, out of the hospital if you can. I bet Dr. Daniels has more.
I would say you guys are the experts in the ED side. So this is, it's a virus that comes in and you see a lot of complications from it. And so I would sort of focus on managing those symptoms and complications as you would.
Your review has a good discussion on vitamin A supplementation. Certainly something that I think many of us in the ED rarely think about. When should we give it, and what's the reason for giving it?
Yeah, so vitamin A supplementation has been well studied in children in low and middle income countries, and it's been shown to reduce the morbidity and mortality associated with measles. But even among children in the U.S. who have been hospitalized with measles, they have seen that some of these children have low vitamin A levels. And so really the WHO and most experts in the US would recommend that we go ahead and universally give vitamin A supplementation to a child who comes in with measles infection in order to reduce the risk of complications. I also think, though, there needs to be education with this, because I think there's been a lot of misinformation surrounding vitamin A. So it's not preventing measles, it's not treating measles, but it is hopefully reducing some of that risk for complications that may develop.
You mentioned complications. Greg, you spoke about a couple of them. What other complications should make ED physicians particularly worried when, say, they discharge a patient with suspected measles, testing comes back positive, and now they're back in the ER for what?
Well, the what that'll bring them back is usually something common like otitis media, dehydration, or pneumonia, but there are some more serious CNS style complications as well, Dr. Daniels.
Yeah, so some of those neurologic complications that we fear, we talk a little bit about acute encephalitis. So that's going to be happening, within the first month of this infection, and so that's going to be 1 in 1,000 cases, and really up to 20% of those children can pass away from that acute process. That's separate from those long-term neurologic complications, that we fear and we talk about later down the road. But even in the acute setting, we can have acute neurologic complications that develop. And then also thinking a little bit about the ocular complications. We hear about the conjunctivitis, but we can also see keratitis and then even corneal ulceration that can result in blindness for these children. And so, there might be a reason to get subspecialists involved if there's concern for, visual impairment as well.
And when we talk about the CNS complications, are they treated differently than they would be if they're not measles related, or are you treated the same way, whether it's measles or another infectious cause?
Yeah, so in the acute setting, I think it's being treated similarly to how we're treating these other acute encephalitis cases that are coming in. So we don't have a specific antiviral for measles, which is what we talked about. So we're really trying to deal with symptomatic management, and then some of the approaches that we use for some of these other viral encephalitis cases.
Another concept you talk about in the review is immune amnesia. Can you explain what that means and why it matters clinically?
Yeah, so this is a very interesting feature of measles, and I think it's an under-recognized complication in general. So when the measles virus, when you get measles, the measles virus itself can actually directly infect and actually deplete your memory B and T cells. And so these are needed to protect us from previously encountered infections and things we've been vaccinated against. So by depleting these cells, we are essentially erasing our immune system's memory. And as a result of that, we may be increased to and more susceptible to, other pathogens in the future. And this can actually last for 2 to 3 years after initial infection. And so you see this in patients who are maybe more prone to developing pneumonia down the road, and other bacterial infections.
So a patient who's had measles in the year or two before is effectively partially immune compromised when they come back to the emergency department. It's
Yeah.
useful to think of them in that way.
And I think it's more pronounced in developing countries, but even in high income countries, they have seen this effect as well.
And looking back at the last few years and then using that information to predict what's ahead, how do you feel the progression is going to happen? Is it going to be similar to now, where there's going to be these pockets of outbreaks, or is this something that every ED clinician in the country needs to, really have a high suspicion for?
Yeah, I'll let you take the lead on that, Dr.
I would say
Connors.
both. We haven't had an outbreak here in our area, Syracuse, New York. In my memory, in the 7 years I've been here, I'm expecting it to come. I think also that sporadic cases, as people travel and then come back to their local communities, measles can pop up anywhere. So I expect both outbreaks and local isolated cases to become the norm.
Yeah, and I think this is one of those viruses we really need more than 95% of a community to remain vaccinated to prevent ongoing transmission. And many parts of our country have fallen, well below that at this point. I did read, a recent modeling study where, they were using an estimate of if we are, if we have a 10% decrease in our MMR vaccination in the US, that could lead to over 10 million cases of measles in the upcoming 25 years. So they've been using these modeling predictions to sort of look at and tell us that I think this is going to be an issue if we don't see a rise in our vaccination rates.
And of course, especially affected will be children with compromised immune systems, kids with cancer, and so forth.
To wrap up here, one of the things we like to do on the blog is the three high-yield clinical pearls that clinicians can take away. We have 2 people here, so I won't hold you strictly to 3, but once the pediatric emergency clinicians that are reading your article finishes it, what are the 3 things that they need to remember when the next febrile rash patient comes into their ED?
All right, I'll start us off. So I think the first thing is, ask about the vaccination status. We talked about, but 93% of these cases are among unvaccinated or unknown vaccine status patients. Keep up to date with our local circulation and, where that patient's traveling. Johns Hopkins has a wonderful interactive map where you can see these outbreaks and where they're occurring throughout the country. And then finally, measles may not present like with those classic 3 C's. And so pause to think about this on your differential, and especially those patients who are high risk because of the first 2 things I pointed out.
I'll chime in one more. It's really important to respect the virus. This is so contagious and so easily spread. So the importance of respiratory isolation, as we've discussed, is just so important. It's going to make the big difference between, keeping a real case of measles contained in the room, or having kids with cancer and other things who are in your emergency department getting exposed to measles and causing quite a few cases. You can make such a difference with a few easy steps.
The review article titled Recognition, Diagnosis, and Management of Measles in the Emergency Department in Pediatric Emergency Care. Danny and Greg, thanks for joining us.